From Sejong Chang-Ha Hospital. We just discussed our two cases. I don't know whether our cases will be informative for managing such complex patients with a small functional RV combined with TR. In clinical settings, it is uncommon to see patients with small functional RV, but patients with PIBS had various degrees of hyperplastic RV. In some abstinent patients, true functional RV is too small for pipe entry repair. And also we have a classic case report of atypical abstinent anomaly reported in 2016. The patient angiogram is similar to our case, showing RV apical hyperplasia. And also last one is patients with isolated RV hyperplasia. This article is about isolated RV hyperplasia, similar finding on small RV on cath angiogram. As you know, there is not much literature about these topics. I want to borrow some ideas from studies about patients with PIBS. PIBS patients, we can proceed with true ventricle, 1.5 repair, and single ventricle repair depending on degrees of RV hyperplasia and T-valve size. If patient RV is too small, we can get the RV to grow by establishing antegrade flow and also performing RV muscle resection, so-called RV overhauling. This is a Congenital Heart Surgeon Society CHSS study in 2004, showing prevalence of endostatus, including true ventricle, 1.5, and single ventricle repair, and their determinants on the basis of RV and T-valve development. They found moderate correlation between T-valve G-score and degrees of RV hyperplasia. Interesting one is that individual institution strategy could determine preference of endostates and mortality. Looking at the institution L, favoring biventricular repair, patients with good RV morphology had biventricular repair. Institution T, favoring Fontaine operations. Patients with even good morphology had Fontaine operations. Comparing to institution L had higher mortality than institution T. So could more aggressive approach favoring biventricular repair could be justified by theory that smaller chance of initial survival is offset by potentially improved long-term functional outcomes. For these questions, I review 3 papers about patients with PIBS from both Children's Hospital in 2006, CHSS study in 2013. Last one is from Netherlands group in 2012. This is both Children's Hospital experience. 19 patients have biventricular repair, mean age is 16 years old. 10 single ventricular patients with mean 13 years of age. Comparing 2 groups of patients with biventricular repair showed superior chronotropic function and more efficient ventilation gas exchange during exercise. However, biventricular repair may not guarantee superior exercise function compared with the Fontaine patients. They categorized exercise performance as subnormal in patients with lower than 85% of peak oxygen consumption. The patients with subnormal exercise performance showed lower auto pulse that reflects the ability to increase the forward stroke volumes. Another one is moderate to severe tricuspid regurgitations. This graph shows influence of age on peak oxygen consumptions. And also they found, regardless of repair types, aerobic capacity may deteriorate with age. So they concluded this study does not support aggressive approach to biventricular repair. This is from CHSS study. Among the neonates enrolled in CHSS study, They included more than 100 patients who had assessment of exercise capacity and functional health status with a mean 14 years following repair. 60% of patients had biventricular repair, single ventricle repair in 24%, 12% patients underwent one-up repair. Patients with biventricular repair had a good initial T-valve, comparing those with single ventricle. Interesting one is there is no difference in functional health status between biventricular and single ventricle. Looking at exercise test, biventricular group had a low peak VO2 than one-and-a-half repair groups. These graphs show linear increase of peak VO2 with increasing initial T-valve G-score. Looking at diagram B, interesting one is in case of low initial T-valve G-score less than -2, peak VO2 in biventricular group tended to lower than those in one-up repair groups. They concluded the functional health status and exercise capacity decreased regardless of the PAIBS repair pathway, and also for patients with smaller initial T-valve G-score, biventricular repair may compromise late exercise capacity, and they emphasized the better outcomes may be achieved for borderline patients with one-and-a-half or single ventricular repair strategy. Last one is from the larger groups. They included 18 patients, 11 biventricular repair and 7 single ventricle. In case of normal or moderate hyperplastic RV or T-valve G-score of more than -2, they considered candidates for biventricular repair. This table shows patient characteristics and results of CPACS. Mean age was 12 years, 13 years for univentricular and biventricular repair. Biventricular repair group patients showed significantly better chronotropic response, VO2 max or O2 pulse. Looking at the job time stress MRI study, patients of both groups showed LV ejection fraction increase during job time stress, but LV stroke volume did not increase in single ventricular repair patients, resulting from abnormal decrease in LV endodiastolic volume, which indicates a problem of LV filling and cardiac reserve. Contrary to previous two studies, this study shows children and adolescents with PAIBS after single ventricular repair have a impaired exercise capacity. Biventricular repair patients showed completely normal exercise capacity and cardiac reserve. These studies from the same Netherlands groups, they wanted to see effect of age on exercise capacity and cardiac reserve in patients with PAIBS after biventricular repair. 10 patients included in this study who had exercise test and MRI study. All patients were asymptomatic, did not receive any medications. Median age was 12 years old, ranges 9 to 42 years old. Median follow-up period after surgical repair was 11 years. This graph shows correlation between patient age and cardiac work indices and stroke volume of RV and LV to stress. They found negative correlation between them. This study showed unfavorable ventricular filling in all the patients. We can consider several factors of RV diastolic dysfunction with age: size and dysplastic T-valve, endocardial and myocardial abnormality of RV, and also surgical procedure can allow RV growth, but may not allowing normalization of underlying myocardial abnormalities. They concluded in all the PAIBS patients undergoing biventricular repair experience diastolic dysfunctions, indicating relatively small and hypertrophic RV at birth may not be capable of maintaining normal ventricular performance in the long term. However, they seem to be emphasized. This finding does not imply that long-term prognosis of PAIBS patients after univentricular repair is better than after biventricular repair. I like finishing my talk after reviewing outcomes of adult PAIBS patients from Okayama University Hospital, Japan, reported last year. 32 patients included in the study, biventricular repair in 24 patients, single ventricular in 5. Median follow-up duration was 7.7 years. 16% of patients experienced atrial arrhythmias. 22% of patients developed heart failure. Risk factor for death or heart failure in adult survival with PAIBS were single ventricular repair and functional status at baseline. This diagram shows summary of clinical course. 4 patients with biventricular repair underwent conversion to 1.5 repair because of heart failure. 2 patients had T-valve and pulmonary valve surgery. 3 patients with single ventricular repair needed a front-end conversion. This is my take-home message. Small functional RV was uncommon and combined with several congenital heart disease. PAIBS most common congenital heart disease showing varying degrees of hyperplastic functioning RV. Long-term outcomes of biventricular, 1.5 and single ventricular repair in patients with PAIBS is still controversial and should be closely followed. Thank you for your attention.